In this chapter, we will review the diseases of the respiratory system. The respiratory system is classified to categories 460 through 519. It is important that you do not assume the presence of a respiratory infection solely from a laboratory report. You must have physician concurrence. It's also important for you to know that it is possible to assign a code for an infection without laboratory evidence when it is supported by clinical documentation. Pneumonia is a common respiratory infection that can be coded in several ways. Combination codes including pneumonia and the responsible organism are included in chapters 1 and 8 of ICD-9-CM. Other pneumonias are coded as manifestations of the underlying infections, as classified in chapter 1, and 2 codes are needed in these situations. When the diagnostic statement is pneumonia without further specification, review the laboratory reports for the mention of the causative agent and query the physician. When the organism is not identified, it is acceptable for you to assign code 486, pneumonia, organism unspecified. Idiopathic interstitial pneumonias, coded to subcategory 516.3, are a group of scarring diseases of the lung of unknown etiology with distinct presentations, pathophysiology, and clinical courses. There are unique codes for several specific types of idiopathic interstitial pneumonias, as well as code 516.30, idiopathic interstitial pneumonia not otherwise specified. It's acceptable for you to use this code when no specific type is documented. Childhood interstitial lung disease is much rarer than the interstitial lung disease in adults. It is typically associated with respiratory distress, shown with diffuse infiltrates on the chest imaging and abnormal lung histology. Plasma cell interstitial pneumonia is an acute, highly contagious pneumonia caused by Pneumocystis carinii. It is frequently seen in AIDS patients and is a major cause of death. Plasma cell interstitial pneumonia may develop also in patients with immunocompromised states due to other causes, such as cancer, severe malnutrition, and debility. Legionnaire's disease is a type of pneumonia almost always caused by the inhalation of aerosols that come from a contaminated water source. It is identified by the presence of bacteria in the sputum, by the presence of Legionella antigens in the urine, or by comparing Legionella antibody levels in 2 blood samples taken several weeks apart. An additional code should be assigned for the responsible organism. Gram-negative pneumonia is classified as 482.83, pneumonia due to other gram-negative bacteria, or to 482.81 when it is specified as anaerobic. When the organism has been identified, the index may provide a more specific code. Gram-negative pneumonia usually appears as a complication of surgery, trauma, or other chronic illness, such as advanced carcinoma, cardiac failure, or alcoholism. A common complication of COPD, chronic obstructive pulmonary disease, and is frequently followed by treatment with immunosuppressive drugs or use of inhalation therapy apparatus. Gram-positive pneumonia, not otherwise specified, is classified to 482.9, bacteria pneumonia unspecified. This type of pneumonia is far easier to treat and requires the expenditures of fewer resources than the treatment of the gram-negative pneumonia. Aspiration pneumonia is a severe type of pneumonia resulting from the inhalation of foods, liquids, oils, vomitus, or microorganisms from the upper respiratory tract or the oropharyngeal area. It is possible for both the type of pneumonia coded to category 507 and that coded to 480 to 483 to be present concurrently. Ventilator-associated pneumonia, VAP, is assigned code 997.31, ventilator-associated pneumonia. A specific code or code for the specific organism should also be assigned. Influenza caused by unspecified or seasonal influenza viruses, in combination with any other form of pneumonia or bronchopneumonia, is assigned a combination code 487.0, influenza with pneumonia. An additional code is assigned to identify the type of pneumonia. Influenza with other manifestations such as laryngitis, pharyngitis, or respiratory infection, whether it's acute or upper, is coded to 487.1. Use code 487.8, influenza with other manifestations, for any influenza with manifestations in body systems other than the respiratory system. Avian flu is a virus that only affects birds and less commonly other animals. Code 488.01 is assigned for pneumonia with avian influenza virus, with an additional code needed for the specific pneumonia. Code 488.02 is assigned for avian influenza virus with other respiratory infection manifestations. Subcategory 488.1 is limited to influenza explicitly documented as being due to the novel 2009 or 2009 H1N1 virus. Codes from subcategory 488.1 should not be used with any other type of H1N1 influenza virus. Code 488.11 is used to report pneumonia with identified H1N1 influenza virus. An additional code is assigned for the pneumonia. Code 488.12 is assigned for other respiratory manifestations with the identified H1N1 influenza virus. Code 488.19 is assigned for other manifestations with the identified H1N1 influenza virus. With subcategory 488.8, there are combination codes to report when the influenza occurs with pneumonia, code 488.81, with other respiratory manifestations, code 488.82, and with other manifestations, code 488.89. Similar to the guidelines for coding HIV infection, codes should only be assigned for confirmed cases of avian flu, the H1N1 flu, or novel influenza A. In this text, confirmation does not require documentation of specific positive laboratory testing. However, confirmation does require provider documentation. This is an exception to the hospital inpatient guideline that diagnostic statements qualified as suspected or possible, such as possible or probable, are coded as if they were established. COPD is the chronic obstructive pulmonary diseases and is made up of the COPD with asthma, COPD with bronchitis, with emphysema, and then chronic bronchitis with emphysema. So care must be used when you're coding COPD to pick up the specific type of condition. Obstructive chronic bronchitis with acute exacerbation is coded to 491.21. COPD in exacerbation, COPD, severe COPD with exacerbation or end-stage COPD, decompensated COPD, exacerbation of COPD, and acute exacerbation of chronic obstructive bronchitis. So it's very possible to have it referred to in many different ways relating to this specific code. Coding does depend on the identification of that specific condition responsible for the airway obstruction, as well as whether it's an acute condition associated with respiratory failure. When the diagnosis states only COPD, review the medical record to determine if a more definitive diagnosis, such as what we talked about previously, is documented. Assign code 496, chronic airway obstruction not otherwise classified when only the medical record does not specify the type and a more specific code cannot be assigned. If your documentation does indicate acute bronchitis with COPD with acute exacerbation, only code 491.22 is assigned. A code of 466.0 for acute bronchitis is not assigned as an additional code. The acute bronchitis included in code 491.22 supersedes the acute exacerbation. Asthma is a bronchial hypersensitivity characterized by mucosal edema, constriction of the bronchial musculature, and excessive viscid edema. Manifestations of asthma are wheezing, dyspnea out of proportion due to exertion, and cough. If there is just wheezing without documentation of asthma, then the wheezing is coded to code 786.07. It is not automatically assumed to be due to asthma. Bronchospasm is an integral part of asthma or any other type of chronic airway obstruction, but no additional code is assigned to indicate its presence. Code 519.11, acute bronchospasm, is assigned only when the underlying cause has not been identified. Acute exacerbation of asthma refers to the increased severity of the asthma symptoms, such as wheezing or shortness of breath. A fifth digit of a 2 is used for asthma referred to as exacerbated or in acute exacerbation. Obstructive asthma, characterized as obstructive or diagnosed in conjunction with COPD, is classified as chronic obstructive asthma, code 493.2. Other asthma is coded as 493.0, 493.1, 493.8, or 493.9. Acute asthmatic bronchitis or asthmatic bronchitis without further specification is coded to 493.9, acute bronchitis with chronic obstructive asthma. Chronic asthmatic bronchitis or asthmatic bronchitis with COPD is coded to 493.2. Status asthmaticus is defined in slightly different ways by different authorities. In general, it represents a patient who continues extreme wheezing in spite of conventional therapy, or who has suffered from an acute asthmatic attack in which the degree of obstruction is not relieved by usual therapeutic measures. Early status asthmaticus is where patients are refractory to treatment or fail to respond to the usual treatments. Advanced status asthmaticus is where patients who show full-blown development of an asthma attack that could result in respiratory failure, with signs and symptoms of hypercapnia, which is the excessive carbon dioxide in the blood. There are fifth digits for asthma, fifth digit 0 for unspecified, 1 for status asthmaticus, 2 indicating the asthma is in exacerbation or acute exacerbation, applies only to codes 493.0, 493.1, and 493.9. An asthma code with a fifth digit of a 2, acute exacerbation, cannot be assigned with an asthma code of a fifth digit of a 1 with status asthmaticus. Only the code with a status asthmaticus digit of 1 should be assigned. You should never assume the presence of status asthmaticus without a specific statement from the physician. Asthma described as acute, characterized by prolonged or severe intractable wheezing, or asthma being treated by the administration of adrenal corticosteroids should alert the coder that status asthmaticus may exist and that the physician should be asked whether the diagnosis should be added. Minor atelectasis is an integral part of pulmonary disease, and it is included in the code for associated lung disease. Pulmonary collapse can be a severe problem, but mild atelectasis usually has little effect on the patient's condition or the therapy being provided. Many times on the radiology report, you will see documented atelectasis, but this is not coded on the basis of the X-ray finding alone. It should be coded only when the physician identifies it as a clinical condition that meets the criteria for a reportable disease. Pleural effusion is an abnormal accumulation of fluid within the pleural spaces. This condition occurs in association with pulmonary disease and certain cardiac conditions, such as congestive heart failure or certain diseases involving other organs. Almost always integral to the underlying disease and is usually addressed only by treatment of that condition. In this situation, only the code for the underlying disease is assigned. Pleural effusion noted only on an X-ray report is not reported or coded. When pleural effusion is due to other bacterial infection, code 511.1 is assigned, with an additional code for the responsible organism. Malignant pleural effusion is coded to 511.81 and can occur due to an impaired pleural lymphatic drainage from a mediastinal tumor, especially a lymphoma. You would assign the code for the malignant neoplasm first, and then the remaining codes, including the malignant pleural effusion. Traumatic effusion is classified to code 862.39 if it's an open wound. If it's a closed wound, then you would code 862.29. Respiratory failure is a life-threatening condition that is always due to an underlying condition. Respiratory failure can result from either acute or chronic diseases that cause airway obstruction, parenchymal infiltration, or pulmonary edema. It can arise from an abnormality in any of the components of the respiratory system, central nervous system, peripheral nervous system, respiratory muscles, or chest wall muscles. Never, ever assume a diagnosis of respiratory failure without a documented diagnosis by the physician. Code 518.81, acute respiratory failure, may be assigned as a principal diagnosis when it meets the definition of principal diagnosis, or as a secondary diagnosis if it develops after admission. When a patient is admitted with respiratory failure and another acute condition, such as a myocardial infarction, aspiration pneumonia, or a CVA, the principal diagnosis will depend on the individual patient situation and what caused the admission of the patient to the hospital. The physician should be queried for clarification if the documentation is unclear as to which of the two conditions was the reason for the admission. The guidelines regarding two or more diagnoses equally meeting the definition of principal diagnosis, Section 2, Part 6, may be applied in situations when both the respiratory failure and the other acute condition are equally responsible for the admission to the hospital. The following chapter-specific coding guideline takes precedence over Code 581.81 when coding respiratory failure associated with a condition from one of these chapters: obstetrics, poisoning, HIV, and pneumonia. When the instructional notes in the tabular list provide sequencing directions, the sequencing of the respiratory failure is dependent on these specific notes. Acute respiratory distress syndrome, or ARDS, is normally a manifestation of an associated disease process. It may occur following shock, surgery, or trauma. You will need to code an additional code if the ARDS is due to an infection. Pulmonary insufficiency is implicit in asthma and various types of chronic obstructive pulmonary disease. It is included in these codes for these conditions, and no additional code is needed. Acute pulmonary edema is a pathological state in which there is excessive diffuse accumulation of fluid in the tissues in the alveolar spaces of the lung. It can be divided broadly into two categories that reflect the origin of the condition, whether it's cardiogenic or non-cardiogenic. Acute pulmonary edema of cardiac origin is a manifestation of heart failure and is included in the following code assignments for left ventricular heart failure, congestive heart failure, hypertensive heart failure, rheumatic heart disease, whether it's acute or congestive. Pulmonary edema is not included in the codes for acute MI or ischemic heart disease, coronary atherosclerosis. When pulmonary edema is present along with one of these conditions, the pulmonary edema is assumed to be associated with the left ventricular failure, unless the heart failure is described as congestive or decompensated, in which case you would code 428.0. Acute pulmonary edema of non-cardiogenic origin occurs in the absence of heart failure or other heart disease, and it is coded in several different ways depending on the cause, whether it be acute edema of the lung, a post-operative pulmonary edema, or post-radiation pulmonary edema, or due to chemicals such as fumes and vapors. It's also possible to be due to aspiration in a near-drowning situation, or when an individual has suffered the effects of high altitude. E-codes should be assigned with any of these codes to indicate the external circumstances. Chronic pulmonary edema, or pulmonary edema not otherwise specified, not of a cardiac origin, is coded to code 514. Pulmonary congestive and hypostasis, unless the alphabetical index or tabular lists give you instructions otherwise. The endoscopic biopsy of a bronchus, code 33.24, is the passing of an endoscope into the lumen of the trachea and bronchus with tissue removed for pathological study. Endoscopic biopsy of the lung, 33.27, goes through the main bronchus into the smaller bronchi and lung alveoli to perform a lung biopsy. Either type of biopsy can be performed independently, or both may be performed in the same operative episode, in which case you would code both codes. A thoracoscopic wedge biopsy is performed when a small chest incision is made and a thoracoscope is inserted to remove specimens for pathological examination. Bronchoalveolar lavage, also known as liquid biopsy, is performed via a bronchoscope to wash out the alveoli tissue and peripheral airways and to obtain a small sampling of tissue. Codes have been created to report thoracoscopic lung procedures and to distinguish them from open procedures. Thoracoscopic procedures involve the creation of a small incision into the chest wall and the incision of a thoracoscope through the incision. And if you notice, a bronchoscope goes through the airway passage, a thoracoscope goes through the chest wall, just to help distinguish between the two. A whole lung lavage, coded 33.99, is a therapeutic procedure performed for pulmonary alveolar proteinosis. The procedure is performed under general anesthesia and mechanical ventilation. The lungs are lavaged by filling and emptying one lung at a time with saline solution. The second lung is usually lavaged 3 to 7 days after the first lung. Ablation of the lung is an alternative to surgical removal of lung lesions. It can be achieved using extreme heat, freezing chemicals, known as cryoablation, focused ultrasounds, microwaves, or radio wave frequency. The codes do not distinguish between the different energy sources used to ablate the tumor. It is important for you to understand and to review the medical record to determine the approach as to whether or not it's open, percutaneous, or through a thoracoscope, or using another unspecified method. Bronchial thermoplasty ablation is the bronchoscopic delivery of radiofrequency energy to reduce excess airway smooth muscle that constricts in people with asthma and in response to certain allergens. It is coded to 32.27. This table shows you several different lung procedures and how the code is specific to whether it's completed as an open procedure or as a thoracoscopic procedure. So care must be used when you're coding these procedures. Mechanical ventilation is a process by which the patient's own efforts to breathe is augmented or replaced by a use of a mechanical device. And either intubation or tracheostomy is performed after admission or in the emergency department of the same hospital immediately before admission, it should be reported. If intubation or tracheostomy is carried elsewhere prior to admission, or if it occurs in the ambulance prior to arrival, it cannot be reported even if the ambulance may be operated by the same facility. So it's really important to determine where the intubation or the tracheostomy was performed. Codes for invasive mechanical ventilation indicate whether the patient was on a ventilator for less than 96 consecutive hours or more than 96 consecutive hours. Continuous invasive mechanical ventilation of unspecified duration is coded to code 96.70. You need to be careful with that because I think our medical records should be able to identify the duration of the ventilation. So to determine how to count the mechanical ventilation hours, it begins with one of these events, either endotracheal intubation performed in the hospital, the ER, followed by the initial mechanical ventilation, or initiation of the mechanical ventilation through a tracheostomy that is performed in the hospital or emergency room, or when the patient's admitted already on the mechanical ventilation after a previous intubation or tracheostomy. You would start counting the hours on ventilation only after mechanical ventilation has actually been initiated. The following are considered part of the duration of the mechanical ventilation, and the hours should continue. And this includes removal with immediate replacement of an endotracheal tube, patients who were started on mechanical ventilation by means of an endotracheal tube who later receive a tracheostomy through which the ventilation continues, and it includes the period during which the weaning process takes place as part of the countdown during duration. The duration also includes the time that the patient is on the ventilator and the weaning period. It actually ends when the mechanical ventilation is turned off. So the mechanical ventilation ends with either the removal of the endotracheal tube, the discontinuation of ventilation for patients with the tracheostomy after the weaning period has been completed, or for individuals who are transferred or discharged while still on mechanical ventilation. Subsequent periods of mechanical ventilation occasionally include the condition of the patient who's been on a ventilator earlier in the hospital stay and deteriorates, and a subsequent period of ventilation may be required. Use the guidelines from the previous slides to calculate this new additional period. Mechanical ventilation used during surgery is not normally coded unless the patient has a specific problem and is maintained on mechanical ventilation longer than expected. When the patient requires mechanical ventilation for an extended period postoperatively, and when the postoperative mechanical ventilation continues for 2 or more days. The physician must clearly document an unexpected extended period of mechanical ventilation. In the counting of these hours, it would start at the point of intubation. Other types of respiratory assistance include a CPAP, continuous positive airway pressure, unless it's provided via a tracheostomy, a bilevel positive airway pressure, or BiPAP, also unless it's provided via tracheostomy, intermittent positive pressure breathing, and non-invasive positive pressure ventilation. It also includes continuous negative pressure ventilation. The treatment duration does not affect the code assignment for these conditions or these treatments. Tracheostomy complications are classified to subcategory 519.0 in Chapter 8, and they include an infection of the tracheostomy. You'll also need an additional code to identify the type of an infection. It includes mechanical complications or other complications such as hemorrhage of the tracheoesophageal fistula due to the tracheostomy.